Hello. Good evening, fellow friends and loved ones. Yes, once again, it's an honor and a privilege to come to your homes as we continue our discussion. Yes, sorry for the leadness and the comment online. Yes, we had a little power fluctuations, and by God's grace, yes, we are back. Yes, we are back. Um, Thank you very much for your wait. Yes, and so we are continuing our weekly discussions on the various health conditions, and today is actually not an exception. And so we are talking about a condition we named developmental dysplasia of the hip. That's a scientific name. And then the common name is dislocation, where we have something moving out of a joint. So that's the meaning of dislocation. So before we start this discussion, just a short quote. The quote is: walk the way I write and trust the way you are led to go. Okay, so it's an anonymous quote, so it just teaches us to walk the right way. Yes, and then everything will be fine. So it takes from the scripture that says trust the Lord with all your heart. So I just want to encourage you that just believe in God, just trust in God, and everything will be fine. Everything will be fine, and God is in control. And so it's 7:33 now. We begin the presentation in the name of the Father and of the Son and the Holy Spirit. Amen. So the condition today is dysplasia of the hip, or developmental dysplasia of the hip. So what is dysplasia? Dysplasia means just dislocation, that is moval of two structures which connect each other. And then we realize that the hip is located just around our waist region. Our hip, when we say hold your hip, you hold your waist region, but actually the hip is actually a bone that has a rounded head and is seated in a small hole called an acetabulum. That's the scientific name. It's an acetabulum. The acetabulum is like this. It's like a hole in your hip. So your leg bone, your thigh bone, fits into that joint around your hip region. That's your waist region, and that helps you to stand. If that joint is not so stable, then you either fall when you're running or you're walking, or you feel pains within the joint, that is your hip region. And so there are so many conditions in the hip that we could talk about, I'm sure, till daybreak, till the next morning. But today, actually, we're talking about the condition dysplasia of the hip. This condition affects mainly infants, that is newborns. It could begin from the womb of the mother right through to infancy, and then it could continue or persist till till childhood. That is when the person is about 6 years. So from birth to 6 years, it might not be noticed during birth or in the mother's womb, but as the child grows up, it could persist and come out. Okay, so this condition was formerly known as congenital dysplasia of the hip. The scientists before time, they thought it was only in the mother's womb that the condition happens, but as time went on, through researches, they realized that when a child is growing also to about 6 years, this condition can also occur in the child. Today, just bear with me with the pictures because of so many things, but I'm sure after the presentation we will see a lot of pictures on Facebook, our Facebook page. Okay, so there are so many types of this condition. There are actually two main types of this condition called typical dysplasia of the hip. Okay, so I told you that the hip is actually two bones coming together. That is the thigh bone, that is the femur, and then your hip bone. Your hip bone consists of so many bones. You have the sacrum, you have the pubis, you have the ischium, you have the symphysis. Yes, so these bones actually, there's a hip bone, fit into a socket called the acetabulum, and then they connect the thigh bone to your hip bone. Then from your hip bone, to your backbone, then your backbone to your neck bone, and then to your head bone. Okay, so we mentioned there are two types of this condition called the dysplasia of the hip or the developmental dysplasia. One is the typical developmental dysplasia of the hip, and then the other one is the teratological dysplasia of the hip. So typical and teratological, these words are so big. Actually, the typical one actually occurs in normal conditions. Yes, you can't really define a particular condition and relate it to this condition where you have the hip coming out of the joint. People say it just happens all of a sudden. It's not related to any family history or genetic condition or anything that the mother has or the father has. Scientists have not really diagnosed the reason for this type of developmental dysplasia of the hip, but well, we still take it as typical developmental dysplasia. The second one is called the teratological dysplasia of the hip. Actually, this one is related to our family. So if your parents or your family members have unstable hips during their growth, you are likely to have it, and then it could show more in you as a newborn. And also there are so many other conditions also that could cause this condition to show itself the more. In our previous presentation, that is some time ago, we talked about a condition called arthrogryposis, where we have stiffness in the hip joint. So we have so many curved position of the hip joint, and so this could cause the hip to be unstable. So this dislocation has three forms. So I'm still hammering on this anatomy. That is the thigh bone. The thigh bone is called the femur, and then the hip bones, that is where when in pregnant women, yes, the baby sits on. So the baby sits on a structure we call the symphysis pubis, and around the symphysis pubis where the baby sits on, we have the pubis, and we have the ischium bone, we have the ilium bone. So these bones are very, very important when we talk about dysplasia of the hip, because they, at the end, that is the side of your hip, we have the acetabulum, that is the socket. So I describe this structure as this. So if this is your thigh bone, this will be your acetabulum. So the thigh bone has a rounded structure at the edge called the femoral head. That is the head of the femur. The femur is the thigh bone. So the head of the femur sits in the socket around your hip. That gives it stability. So scientists will say that the femur, that is the thigh bone or the hip joint, sacrifices mobility for stability. That means that it doesn't allow too much movement, but then it makes sure that you are very stable so that you don't fall. So that's why people are able to run as fast as they can, and then they are not able to fall, because that joint is very, very strong, and then it's deep. It's not so shallow like the shoulder joint. You can even touch the shoulder joint. The shoulder joint is very, very light. You can even feel it, because it allows mobility in place of stability. It's not so stable, but it allows mobility. Okay, so we're talking about the hip joint. So I mentioned that you have three types of the dislocation, the forms of dislocation. One, you have the complete hip dislocation. So you can have, if this is the hip joint, that is your thigh bone, and this is the acetabulum, you have something inside we call the labrum. It's a cartilage, that is an articular cartilage. That is it prevents the bone to bone interaction, because when the bone interacts with the bone, it could cause wearing away, which could lead to other conditions such as arthritis. I'm sure you have heard of arthritis before. That is, we have joint pains in the hip. But then when you don't have arthritis and you have the labrum, that is articular cartilage, intact, there could be dislocation in the hip joint. As I mentioned, it's in newborns or up to 6 years. That's when this condition is diagnosed, and then it's treated as early as possible. So if you have this dislocation, that's complete dislocation, you could have, if this is the hip bone, you could have the bone off. So if this is a joint, the hip bone is here, and then the joint is here. So complete dislocation of the hip. And then we could have the second one, partial dislocation. So if this is a hip, if this is the acetabulum, that's the socket, instead of the thigh bone sitting in the joint like this, it comes off a little, so you could feel some space around the side. So you see the space around the side, and so with little movements you could see the hip going off and in, off and in. That is we call partial dislocation of the hip. That is the hip, that's the thigh bone, is not able to sit in the joint called the acetabulum joint, or generally we call it the ball and socket joint. So the third one is called hip dysplasia. That is when we have incomplete displacement or development of the bone. So the third one, that the third form of hip dislocation, is what we are talking about today. That is incomplete development. So under normal circumstances, between the 7 to 8 weeks postnatal, that's after birth, there should be a joint, this joint forming, the acetabulum joint, that's the ball and socket joint. In the mother's womb, the joint is not so deep. We have more cartilage formation, that is bone formation. And actually, when the baby is born, the bone is not fully grown. There are spaces in the bone. So if you have the thigh bone, if this is a thigh bone, the ends of the thigh bone, we call them epiphyses. So they are not so hard. So as we grow, the bone becomes long and long and long. That's why we see the baby small. Then when the baby is growing, the baby becomes big, because the bone becomes long, and then the edges have the structure of becoming longer. So that is what we are talking about. So the edge of the bone becomes soft. Yes. So that's what we call the epiphysis. And then the hip joints fit into the socket. Yes. So within the 7 to 8 weeks of development of the newborn, these joints begin to form and become deepened, and this allows for stability of the hip joint. So in the case where this condition, that is hip developmental dysplasia, comes about, the joint is not deep. Either the joint is not deep, or the joint is formed out of the hip bone, that's the thigh bone, goes a little bit out of the full joint space. So if this is the joint space, if this is the joint space, you can see this, my hand, I'm doing as a joint space. The hip is supposed to sit in like this, but then the hip bone comes off like this, and you could feel some small space around here. You could see the space, and so we would have instability in the hip joint in terms of these children. So when they are born between 0 months to 6 months, or 6 years to 6 years, they're not able to perform some movements that are working very effectively. And so some statistics say that from out of 100 people, either one, or out of 250 babies, either one of them have this condition we call the hip dysplasia. And actually, this condition is marked in geographic and in racial variation. That is, so many people could be affected by this condition. People from Sweden, yes, research carried outside referred to people from Sweden, and then people from Yugoslavia, and then Canada, as people having this condition more prevalent. They found out because that when the baby is born, actually they have a way of carrying the baby about. So you can see that they carry the baby about up and down and open legs and shaking the baby, and in this case it causes instability in the hip bone, because the hip bone is not even so strong. But if you look at in our part of Africa, when the baby is born, the mother is carry the baby close the body, and so the hip joints are fully closed and then static. So it allows the very good formation of the hip joint, that's the ball and socket joint. And so it's showing that there's not much research carried in Africa, but compared to outside, it's showing that they are more prevalent in Canada, Canadian and Swedish countries. Okay, so and then also in Asia too, there's less prevalent in Asia. Okay, so actually in Americans, that's in these Americans, Native Americans, this condition is also more prevalent, and then Eastern European cultures. Okay, So what are the causes of this condition called developmental dysplasia of the hip? Yes, actually it's shown that about 12 to 33% of people in a family who have this condition, yes, you could pass it on to your baby. Yes, if you have this condition, the probability of the mother and father passing on to the baby is 12 to 33% of 33%. Yes, and also it's more common in females. Yes, why is it more common in females? Because scientists have realized that females have a condition, a hormone we call, a hormone is actually a substance that helps to improve upon a particular structure. A hormone we call the relaxing hormone, and this relaxing hormone helps to relax and give flexibility in the joints of females. And that when the female is going to give birth, the joint is supposed to relax for the baby to come out. The same thing that in baby females, yes, this condition, this hormone is present. It's called the relaxing hormone, and this predisposes the females to having this condition, female newborns to having this condition called the developmental dysplasia of the hip. Okay, and then also we have another cause. Also, one is we call it in a scientific term pregravida. Sorry. And so when this is a firstborn, you are likely to have this condition. And also when the child is born with the legs coming out first, so we call it in scientific term, we call it breech presentation. So when the baby is being born, instead of the baby coming up with a head, the baby comes out with one leg before the other. And so in the terms of bringing or twisting the leg or the other leg coming out, the person is likely to dislocate the hip, and this will cause hip dysplasia. And then it's noted that this condition is more prevalent in the left leg of the newborns. Why? Because most individuals are right dominant, so the child could come out with the right leg first, but then bringing out the left leg, the turning processes sometimes do not go on well, and so then you could have dislocation in the left hip. So that is why the left hip or the left leg is mostly realized to have this condition called the developmental dysplasia of the hip. Okay, another good condition is also due to adductor and extension postnatally. So you could learn that when the baby is born, you mostly try to cross the leg or cross the leg like this. And so in the crossing of the leg, it causes the hip bone to move upwards and then outwards. And this actually is not that good, and this will cause developmental dysplasia of the hip. So in case you have given birth or you have a newborn or you have a relative who has a newborn, avoid trying to cross the leg as often as possible, because the joint, that is the hip joint, is not fully formed yet. You could cause the child to have this condition where we have developmental dysplasia of the hip, that's the hip coming out of the joint, and this is very difficult to treat. Sometimes it leads to surgeries, so we have to take caution. Very, 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 very important. Okay, other condition that's cause developmental dysplasia of the hip is we have something we call the calcaneovalgus feet, where you have cross knees, so knock knees. So many conditions. You have torticollis, you have metatarsals adductors. They are scientific names. We don't want to go into details. Okay, so aside these causes, what are some of the risk factors that could cause this condition called the developmental dysplasia of the hip? We've mentioned that when someone has the females are more affected. That is the presence of the hormone called relaxin. And also another reason is the fact that some of the children have shallow acetabulum. So during development in the mother's womb, the acetabulum, that's the hip where the thigh bone fits into the hip bone, is not fully developed. That is shallow. So instead of it having its deep nature, it's shallow, that it's not able to fit into the joint well. So then the person could have this condition called developmental dysplasia of the hip. And there could also be structural abnormalities, such as probably the child doesn't eat well, so the bones are not able to very well form, or the mother does not take in iron supplements very well. And actually the diet of the mother during pregnancy is very, very important to ensure avoidance of this condition from coming to bear. Also, we could have femoral acetabular anteversion. Actually, it's a scientific word. It's a big word. Femoral acetabular anteversion. So you could simply put if this is the hip bone and this is the joint, there could be a superior, that's upward and lateral displacement of the bone. That is, the bone moves upwards and then upwards and outwards, and this could cause the bone to likely move up the joint as often as possible. And so when this is noted or assessed as early as possible, there could be immediate treatments that could be full recovery. Yes, especially within from birth to 6 months, there's 90% full recovery of this condition. Okay, so I mentioned that yes, the high probability of this condition occurring is because of the fact that yes, after birth outside, they don't carry the child as we are supposed to. So maybe when the child is 9 months or 6 months or 4 months, they carry the child and they don't keep the child close to the legs close to each other, so they open up, as compared to Africans who do keep their legs close to each other for some time. That is, we call it adduction. So the legs come close to each other. So if these are my hips come close to each other, and then it allows formation of the joints very effectively. The cerebellum is fully secured and the thigh bones sit in the socket. Okay, so what are some of the characteristics, or how do this condition present in the hospital? So when you see a newborn baby, how will you know that the person has developmental dysplasia of the hip? One, the person has an unstable femoral head. That is, if this is the thigh bone, we have something we call the femoral head. That's the head of the thigh bone, and then we have the neck around the side. So the head is not so stable. So there's two tests that we perform. We have the Ortolani test as physiotherapists or medical professionals, and we have the Ballows test. And these two tests are very, very important and essential to be able to diagnose this condition as developmental dysplasia of the hip. And also, there is the fact that there's instability of the femoral head. It could also be in two reasons, in two situations. The femoral head can be, that's the thigh bone head, can be unstable, but it could be unstable and move, if this is, can move within the joint. And so this could also mean that the person could have a milder form of the developmental dysplasia of the hip. And then the second one is where we have the unstable hip, that's the unstable thigh bone, moving absolutely off the joint. So if this is the head of the femur, and this is the socket, the thigh bone, that's the head of the femur, is off. So instead of it staying here, it moves here. And so when the person is walking, the person is likely to limp on one. So if you see that the person walks and one leg is longer than the other, this could mean that the person could have developmental dysplasia of the hip. It doesn't mean maybe the person has broken a leg and so one is longer than the other. This one also can cause one leg being longer than the other because it doesn't fit into the joint. So if this is the thigh bone and then the thigh bone goes off the joints, you could see that there could be a length deficit. That is, one, instead of this length like this, it takes off this length. Instead of it like this, it takes off this length and now comes off. So the whole of this length is off. So when you're standing, this length will show that instead of it's like this, you stand like maybe like this, or you stand like this. So because one leg will drop to compensate for the thigh bone coming off the joint. Okay, so we've talked about how this condition presents itself, and so we also have one presentation that we have uneven skin folds. Yes, so when we hold the thigh of the newborn and then you open it up, we could see that underneath the thigh bone, getting to the butt area, we could have one lines around the other one side, and then the other one don't have lines. And actually, when you move the hip bone to a particular angle, you should see skin fold, that is lines within the skin. That shows that yes, the skin have folded into one direction. But when you open and you don't see skin folds in one direction or even both direction, it could be that the person could have, if it's only one direction, the person could, if the skin fold is seen in one portion and not seen in the other, where it's not seen the skin fold, that's the lines are not seen, the person could have unilateral developmental dysplasia of the hip. Or if you don't see the lines on the skin when you open up the legs on both sides, the person would have a bilateral developmental dysplasia of the hip, that's DDH. Okay, so and also the person has less mobility and inflexibility in one side, that's the person limbs. Yes, so if you realize, if you look at newborn, so from 0 to 6 years, you can see that the person could be limping on one leg. Yes, so the person is walking and as if the person one leg is longer than the other. Okay, so another one is the person could toe walk. So when the person is walking, the person stands on the toe and walks toe walking. Other ones too, also the person has huge butt. Yes, so because of the instability nature of the hip, there is hardness, that is big. The person likes to have big buttocks, that yes, to compensate for the fact that the person has dysplasia of the hip. That is what some scientists have said. Well, we are yet to have a confirmation. That's what research has said, and we obey research, we listen to research. Okay, so when we look at, we have some types of classification of this condition. We have 4 types of classification of this condition. One, we have the Crow one. So the person who did this, actually, he classified this condition under 4 types. His name is Dr. John F. Crow. The Crow is spelled CROWE. He classified it under 4 types. So the first one, he said that if there's minimal abnormal development of the hip, that is in utero, in the mother's womb, there could be less than 50% dislocation of the hip. So if this is the type 1 and this is the joint, there could be 50% dislocation and you could have 50% of the hip in the joint. And then the second classification by this man called Dr. John F. Crow, he said that there could be abnormal development of the acetabulum. That is, this one is called the acetabulum and this is called the thigh bone. When this acetabulum is not developed well, there could be inconsistency in the circular nature of the acetabulum, and then the joints also will be compromised. And then he also said that there could be a false acetabulum. That is a false acetabulum, that is the joints not being circular in nature. There could be about 50 to 75% dislocation of the joint. There could be high probability that the joint will dislocate, that the bone will come out of the joint. And then the third classification was that there could be a false acetabulum. That is, there could be development opposite the head of the femur or opposite the femoral head position. So if this is the femur, it could move like this and off the joint. But he's saying that the third type of classification has a relatively higher one than the second one. That is 50% to 7%, 75% dislocation. Then the last one is where we have the insufficiently developed acetabulum. That is, the acetabulum doesn't develop well, and so the bone comes off totally from the joint. And so we have 4 main types of classification of this condition called developmental dysplasia of the hip. And so we have differential diagnosis, that is other conditions that could look like this condition called the hip dysplasia. We have the hip joint anteversion, we have hip strain, we have athletus pubalgia, that's a pain in the hip, we have osteitis pubis, we have osteoarthritis, we have osteomyelitis, we have so many conditions, inflammatory arthritis, septic arthritis, we have piriformis syndrome, we have snapping hip syndrome, we have so many, we have tumors in the head, we have hernia. Yes. Okay, so aside this, how do you manage this condition? Okay, we have surgical procedure to manage this condition, we have the medical procedure to manage this condition, we have the physical therapy management. So first of all, when we look at the surgical management, which is tends to be the last one, we have so many procedures, but maybe we can look at, before we look at the management, let's look at how we diagnose this condition. Actually, this condition in the newborns is actually not painful, so the child doesn't complain of pain. The child doesn't complain of pain, so he says that he can't even talk because the newborn doesn't have the ability to talk, he doesn't reason well, and it's not painful, and so the child doesn't cry. So you don't notice it. But then we have physical examination that we can be able to see or tell that the person has a dislocated hip. So as medical practitioners, as medical doctors, as physiotherapists, we have two major tests that we carry out, and then if they're positive, or we have additional tests such as that we call provocative tests, that we're able to diagnose this condition as hip dysplasia or developmental dysplasia of the hip. The first one is the Ortolani's test. Actually, it's done by orthopedic surgeons to be able to, as early as possible, diagnose this condition. So they'll hold the two legs of the child, that's the thigh bone, and so they'll bend the hip forward. So we call it flexion of the hip, and then they'll bend the knee also downwards. That is flexion of the knee, and then they're going to try and open up the leg. They can do it, it's mostly done one after the other, so that we can observe and differentiate between whether it's one side or both sides. So they bend the hip forward and then open it, that we could call abduction, and then there's a little bit of flexion. So in the case where there is dislocation or they hear a sound in the hip, that could mean that the hip is located. It's a slight sound that is, it needs very, very good hearing to be able to diagnose this condition. We also have the Barlow's test, similar process. And so if these tests are positive, then we go on to treat. Actually, sometimes we could have a negative test for this condition, that is using the Ortolani's or the Barlow's test. But then after 2 weeks, the doctor or the orthopedic surgeon is supposed to carry out the same test again, because it could be that it didn't show up as within the time of birth. So after 2 weeks, the pediatrician or the orthopedic surgeon also carries out the same test again to be able to rule out this condition called the developmental hip dysplasia. We have other tests we call the ultrasonography by radiographers. We have the MRI, we have the CT scans, we have the sonography examination. So these are all tests that we can be able to help conclude in diagnosing this condition. Aside the tests, we also have medical management. So medical management actually starts from birth to like 6 years to go to reduce the adverse effects of this condition. So when we know this condition and then we are able to diagnose this condition through the MRI, through the test, through the special tests, we do something we call splinting. So we hold both legs in a particular angle. So open the legs of the newborn to a particular angle. It could be beginning from 0 degrees, that is the leg straight, and then open it up to about 80 degrees. But sometimes in the initial point, you're unable to open the legs up to 80 degrees, so you open it up gradually. And so we splint, that is, we have something we could use a thermoplast, we could use a spiker, that is where in a very serious or after surgery. Okay, so actually this is very important. Splinting is very important to be able to hold the hip in place so that the joints become, that is the structures in the joints form very well and then hold the hip in place. But then when you do the splinting for a long time, there's a condition also that can result, we call femoral avascular necrosis. That is where blood supply is not able to go into the hip because there's no movement in the hip. Where there's no blood is going there could be deadness of the structure there, and there could be also something we call blood circulation, poor blood circulation. And so we also from time to time monitor this condition to be able to reduce the tendency of this condition from happening. And so we are, as physical therapists or medical practitioners, are supposed to provide favorable conditions for this dislocation to be able to heal. And as I said initially, 90% of this condition of people are able to recover very fully. Aside the medical management, we also go through a process we call close reduction, and this helps also to hold the hip in place for the joint to form very well. Actually, within some few months, the hip is supposed to be formed very well, and the joint is supposed to be very stable when it notices very early. The close reduction I was talking about, it takes about 1 year, 6 months, and then everything becomes fine. That's when noted early. But when this condition is not noted early, then surgery is the last option. Yes, so we are all encouraged that when we notice this, that the child is not so stable, and then one leg is longer than the other, we report to the hospital as early as possible. We have other procedures we call the weight traction, and this helps also to pull the leg downwards and then push the hip bone in place. So if it's off the joint like this, so we're going to pull the leg down and push the leg in place like this, and then stabilize it for some time. And this could take about 6 weeks for the bones to fully get intact, especially in newborns to about 6 months old. Okay, so aside this surgery, also it's important that we give the child the right nutrition, or we also eat the right nutrition. We also have oral glucosamine, that's a medication, oral glucosamine, or we have shellfish. Shellfish is a natural food that helps to allow bone growth and then formation of this cartilage, as we mentioned earlier on, the articular cartilage, and this helps to make the joint also firm to hold the hip in place. Okay, we have also people looking out to going vegetarian, that is taking in leafy vegetables, and this also is very good. And also taking in fish oil supplements, taking in nuts, broccoli, cauliflower, spinach. I'm sure you know spinach. The ladies know spinach very well. And also it's good to eat tomatoes, potato, eggplant, red pepper, and then this helps to allow a good development of the hip. Aside this, doctors, when you notice that there's slight pain, because as the child grows, the bones form more, and then when they come into contact with each other, there could be pain. So there could be also giving of medications we call NSAIDs, non-steroidal anti-inflammatory drugs, and this helps to reduce the pain and also reduce swelling or likely swelling of the hip region. And also we also not advocate the use of cortisone, that is by medical practitioners, because it could also and even don't also advocate, because it could also cause the weakening of the structures in the hip. We have structure we call ligaments, and ligaments connect bone to bone. So if the ligaments are weak, then under symptoms the bones also will not be stable, and this could predispose a more severe type of this condition called the hip dysplasia. Aside that, surgical management also comes to place. We have open reduction, we have bone surgeries that's done, osteotomy. So the open reduction, actually the surgeon cuts into the bone, into the tissues, and gets the capsules and realigns the femur bone into the joint. So if it's like this, the surgeon cuts the capsule like this and then realign the head of the thigh bone into the joint and stabilize it for some few weeks, so that the joints form very well. Aside that, we also have, as I mentioned, bone surgeries, that is we call osteotomy, and then also we have soft tissue surgeries in younger females or younger children. Also could have hip replacement, because we also have arthroscopy. We could also have stem cell, that is we have grafting. We could culture some cells into the hip joint, and this helps also to grow the bone naturally and then keep the joint stable. Before the child grows into a child, an adult. Aside everything, we also go through physical management. So if there's pain in the joint, the physiotherapist comes to use ice as early as possible to reduce the pain, instead of taking medications or taking in the cortisone to reduce the pain, which has adverse effects on the ligament. We could do icing, we could do gentle exercise such as isometrics. So you squeeze the buttocks, and this helps to keep the joints intact and then also prevent further displacement of the joints. Also, we have a very good device we call the pelvic harness by physical therapists. So we fit it into the child, and this helps keep the joint open up in a particular angle, and this helps healing by resting. Okay, aside everything, we also have a pillow we call the surgical pillow, and this also helps to keep the legs open, especially when the child is asleep. And then this prevents also the condition becoming worsened. The other complications, as I mentioned earlier on, that we have the femoral avascular necrosis. That's the head of the femur becoming smaller, because there's no blood supply and there's no movement in the hip. So when you use this, we call the surgical pillow or the pelvic harness, that is the one that opens the leg up, it will lead to poor supply of blood in the hip. Okay. Aside that, we could also have traction, as you mentioned earlier on, and then we could also allow small movements in the hip, and this helps to also prevent this condition called the femoral avascular necrosis from occurring. Last but not the least, we also have a condition, a treatment we call the hippotherapy. That is actually practiced outside. It's not actually being done here because we have less of this condition in Africa and in Asia. So we call it hippotherapy. So the whites get horses, and then the child sits on the horse, and so this also helps to allow the child to participate in this treatment. So the child sits on the horse with the legs open, and so as the child is walking, or the child is sitting on the horse and the horse is moving about, it also helps to ensure that there is good fixing of the head of the thigh bone, that is the femur, in the joint, and this also helps in recovery. 90% of children or newborns recover from this condition. That is a very good plus to treatment of this condition. Okay, so I'm sure that we have learned a lot, though there are no pictures, but I'm sure the graphical representation that is through my hand, we've understood a lot. And so if you have any question, we can ask any question. All questions are welcome. And so okay, so yeah, so many people were online, and I thank you very much for your presence. Yes, so we have Patricia, we have Emmanuel, we have Tayo, Mr. Tayo, we have Shima, we have City Physiotherapy, yeah, we have yes. So thank you very much for your time, and so many pictures will be shown on this platform after the presentation, and I'm very glad for your time. Yes, and it's been an awesome time as we discuss this condition. So we talk about the condition developmental dysplasia of the hip, that is hip dislocation, which occurs in newborns to about 6 years. So thank you very much. So our next topic is actually also a very important condition. It's called pleural effusion. That is fluid in your lungs. Initially, we talked about the condition called pneumothorax, that is air in your lungs, but this one is called pleural effusion, that is we have fluid in your lungs. So I'm sure we'll be very we'll enjoy the discussion next week. Thank you very much, and have a blessed evening. May the Lord be with us all. Have a blessed week, and see you. Bye.